Hey, I'm Dan. Today I'm going to be talking about MDMA-assisted therapy for alcohol addiction. This will be mostly a high-level overview and primer of research to date, and then I'll go over some future possible directions right afterwards. So first off, what is MDMA? Well, MDMA is short for quite a mouthful, 3,4-methylene dioxymethamphetamine, and it's a synthetic phenethylamine first synthesized and patented by the German pharmaceutical company Merck in 1912. The drug's subjective effects went largely unnoticed for decades until the 70s and 80s when it became referred to as atom and empathy within clinical and therapeutic settings because it had certain effects like anxiolytic effects, prosocial effects, and euphoric effects on patients when treating trauma-related and anxiety-related psychopathologies. The drug also quickly became synonymous with the term ecstasy as usage broadened to recreational settings like clubs and raves. And unfortunately, due to the timing of the drug war, this led to an arguably premature emergency Schedule 1 classification by the DEA in 1985, before sufficient research into the risks and benefits of the compound could be conducted. Now, the chemical structure of MDMA contains the phenethylamine core structure, where the primary amine, or the amino group, is attached to a benzene ring through a two-carbon ethyl group. MDMA belongs to a unique drug class known as entactogens, previously referred to as empathogens for their reputation as prosocial substances. And entactogens are structurally distinct from other drug classes like stimulants, hallucinogens, and classic psychedelics. And as for the name change, I'm assuming that empath has a nice connotation, pathogen, not so much. Now, entactogens, in addition to their subjective effects, have this unique dioxygen structure that's attached to the phenethylamine core structure. So some other drugs that you might have heard of that are entactogens also include MDAI and MBDB in addition to MDMA. Now, in humans, 75 to 150 milligrams of MDMA produces subjective effects that last for several hours. The visual effects of MDMA are often in contrast to the complex and systematic visual hallucinations that characterize classic psychedelics like psilocybin, DMT, or LSD. The visuals experienced from MDMA tend to be pretty ill-defined and are often described as peripheral flashes of light in the populations that have been studied so far. Furthermore, this hallucinogenic component of the experience is pretty uncommon still, and it only appears in about 20% of users. Now, overall, popular notions often conceptually refer to MDMA as an empathy drug, but present evidence and research actually remains mixed as to whether MDMA results in enhanced empathy, partially due to the broad definition, I think. And there's some research that's pretty interesting concerning MDMA ingestion and oxytocin release that you can check out. If you want to learn more, feel free to email me at the end of this and I'll send you it. 90% of subjects across clinical trials do report a heightened sense of closeness, and generally it is agreed that users experience perceptual alterations often accompanied by elevated mood, increased prosociability, and an increased sense of inter and intrapersonal connection. Now, before I continue, I want to dispel some misconceptions concerning the safety of MDMA. And first off, clinical MDMA is not recreational ecstasy, and their safety profiles are quite different. Clinical MDMA has been administered to 1,775 people with only one serious adverse event occurring, and at follow-up, that event did not result in lasting harm. Concerning side effects, clinical MDMA does end up resulting in mild increases in body temperature, blood pressure, and heart rate in concordance with elevated cortisol levels following MDMA administration. You might also experience common side effects like like dry mouth, muscle tension, lockjaw, as well as perspiration. And these effects probably result from the amphetamine-like properties of the drug. Psychologically, the most common acute reaction is anxiety. Now, concerning recreational ecstasy, severe reactions, although rare, such as hyperthermia and acute kidney failure, has occurred as a result of recreational use of ecstasy. These reactions are notably absent within clinical trials again, and so they might be partially attributable to risks distinctly unique to recreational setting. This is polysubstance use, so sometimes substances sold as MDMA often contains amphetamines, cathinones, and other potentially neurotoxic substances depending on the dosage. Latent potential for adverse symptoms environment-wise, such as hyperthermia, might be exacerbated by physically active settings where high temperatures and dehydration is often present. Now, concerning dose and frequency, clinical trials can control for addictions to substances as well as the doses of the drugs being administered. So if you look at the general population that recreationally uses ecstasy, frequent users of ecstasy perform worse than the general population on cognitive measurements and are associated with higher prevalences of depression and anxiety. But in recreational use too, people who use it at a comparatively moderate frequency don't share those same cognitive impairments as frequent users compared to controls. And if you scale this down, additional acute effects of MDMA or clinical recreational ecstasy, such as memory impairment, is not present in low doses, but it does begin to appear intermittently at higher doses. Now, the treatment model of MDMA-assisted therapy is similar to other psychedelics that induce intense effects for relatively extended durations that you need to be accompanied for. So far, the bulk of studies for MDMA have focused on the treatment of post-traumatic stress disorder. And so typically these follow a linear format where there's an initial screening for substance use disorders, as well as other primary personality disorders, disorders with psychotic features, and so on. And after that screening, if you pass that screening, you're taken through a preparation therapy phase where you're told what the drug might be like, how to cope with certain effects of the drug, how long the experience will be, things that you can do, what you'll want to address in that session specifically. Following that, you will have a dosing session, which typically involves ingesting about 120 milligrams of MDMA, followed by an optional upper dose of 40 milligrams administered about 2 hours after the initial dose to extend the therapeutic effects. Now, these effects can last as long as 8 hours, during which the patient has the opportunity to revisit important past events and emotions with trained facilitators and therapists. Between these dosing sessions, usually which there are 2 or 3 within a 12-week period, you have these preparation and integration therapy sessions that help you consolidate your therapeutic gains. At the end, you get a standard endpoint assessment based on the DSM-5, which is something psychiatrists use to classify mental illnesses. And intermittently afterwards, you get follow-up assessments at several months and a year, just to see how long your benefits, if any, have stayed up and how strong the benefits have been over time. Now, within therapy, MDMA is thought to work by reducing the emotional intensity associated with traumatic memories by reconsolidating traumatic memories during psychotherapy in a way that they're stored with less excitatory activation. So you might respond disproportionately emotionally to a trigger that someone who's healthy or doesn't have post-traumatic stress disorder might not respond to in the same way. And so far, an MDMA might sort of allow you to reduce or regulate that type of intensity in a safer environment. And so far, the results are quite promising. An overall remission rate of 67% with low rates of adverse effects across all 3 clinical trials is noticeably more effective than some of the standard treatments that are federally approved today. And this has led to the FDA, or the Food and Drug Administration, granting something called priority review of a new drug application for MDMA-assisted therapy. And this is quite rare, so it has generated quite a bit of excitement. Now, before I get into addiction and alcohol addiction specifically, I think it's important to line out the parameters and the public health risk of alcohol use. So heavy drinking typically for men is consuming 5 or more drinks on any day for 15 or more per week. For women, it's classified as consuming 4 or more on any day or 8 or more drinks per week. And generally, the feds basically define heavy alcohol use as binge drinking on 5 or more days in the past month. And this is a pretty big societal cost. 42% of those receiving treatment for alcohol use disorder will relapse. 14.5 million people as of 2019 were struggling with alcohol addiction, and the estimated annual cost of maladaptive drug and alcohol use in the US is estimated at $442 billion. So it's a sizable public health issue. Now, some other psychedelics have been used in experiments to treat alcohol use disorder. LSD, in a meta-analysis of 6 trials of 536 patients, found a beneficial effect for treating alcohol use disorder. Psilocybin, in a meta-analysis of 3 clinical trials, also seem to have significantly beneficial effects for alcohol use disorder symptoms and substance use. Now, as stated before, MDMA might induce a kind of supraphysiological or elevated form of memory destabilization, which may allow you to magnify your ability to reconsolidate and extinguish certain behaviors and responses that might be maladaptive in a safe environment. So you might be able to have safe, non-reinforced exposure to typically strong associations with emotional or fear-based memories. The question, though, is MDMA-assisted therapy seems to be great for PTSD. Is this phenomenon of memory destabilization, if true, is that phenomenon unique to just fear and trauma, or can it be applied to other behaviors such as addiction? Because post-traumatic stress disorder does increase the risk of developing substance use disorders and addictions. So perhaps this is something that could be explored. Well, it was explored. In the MAPS study, phase 2 and 3 of post-traumatic stress disorder, actually, MDMA, they took a cohort of individuals with mild to moderate alcohol addiction, and they found that MDMA-assisted therapy was not associated with an increased risk of illicit substance use, but it was associated with greater reductions in alcohol consumption and a lowered risk for hazardous use of other substances. And in a safety and tolerability study of 14 people with only alcohol use disorder, because the last study had people with comorbid AUD and PTSD, it could be an extension of reductions in PTSD symptoms. Well, MDMA treatment was well tolerated by all participants when this study was treating only people with alcohol use disorder. Psychosocial functioning improved across the cohort. No unexpected adverse events were observed. And at 9 months post-detox, the average units of alcohol consumption by participants went from 130.6 units per week to 18.7 units per week. And this compares favorably to a previous observational study, the outcome study in red, seen here, by the same team with a similar population of people with AUD. So overall, out of the 14 people from that study, 9 people were completely abstinent and achieved remission. Nearly 50% of individuals who relapse do so within the first month of sobriety. Research studies show that 65% to 70% of abstinent alcohol-dependent subjects relapse within 1 year. So this is quite promising. If scalable, these results would, similar to the PTSD therapy, would also generally be superior to other pharmacotherapy options for alcohol use disorder, like naltrexone and acamprosate and disulfiram. But we should not take this too heavily yet because the sample size is relatively small. Now, I am cautiously optimistic about these results, but I think it would be irresponsible not to mention that psychedelic therapy is still in its infancy, and it's not immune to issues that already plague the field of mental health in general. It's one of the investigators associated with the Imperial College London Safety and Tolerability Study that I just was talking about ended up having personal relations with a patient that later ended, the former patient that later ended up in them breaking up, and the patient unfortunately, and the person unfortunately ending their own life. Luckily, this was not related to the study. It was in his private practice, but generally, it's important to note that this is not the first time this has happened. Some reports of SA have happened in traditional retreat settings and have even made their way into more official organization studies such as MAPS. Now, generally in therapy overall, people who have experienced past abuse are tragically more likely to end up in situations where the patient-provider boundary ends up crossing over into unethical territory. And we are not immune. Psychedelics promote not just elevated suggestibility, but also elevated vulnerability. And that must be treated with great care, given their tendency anyway to dissolve traditional social boundaries and customary ways of human interaction. What we don't want to happen again is premature drug criminalization. And one adverse effect of premature drug criminalization is that we lose the ability to regulate the supply of substances, as well as the purity and dosage. So our substances that are used in the public space become more and more unsafe. In the US, as of 2016, Europe faced a flood of high potency ecstasy pills, but the US had the opposite problem with a lot of pills being sold as ecstasy or Molly that contained little to no MDMA. 30 to 60% of what was being sold as Molly um, did not have MDMA and contained synthetic cathinones, methylone, butylone, ethylone, and even bath salts, which are designed to mimic the effects, but don't always do so. In the UK, after supply chain crackdowns related to Brexit, the prevalence of MDMA in such samples dropped from 93% to 55% in samples taken from the black market, excuse me. And again, we find synthetic cathinones, caffeine, amphetamines in a substantial proportion of samples. And these are substances which were non-existent before the crackdown on the supply began. And I'm not encouraging any recreational use. Again, it can be kind of dangerous sometimes, but if you do, please test your drugs. See dancesafe.org for more information. Now, some next steps for this research. The line graph from earlier is a comparison to an observational study of participants undergoing typical rehab, not a control group or a placebo group that thought they were receiving MDMA. So naturally, a randomized control trial with a larger sample size would be a good next step. We could also have neuroimaging and cognitive studies to look at the effects and the physiology of the memory reconsolidation to see from other research if that's actually what's happening. With a larger sample size, and specifically with a sample size that includes people with severe alcohol use disorder instead, you as well, you can look at withdrawal symptoms and how MDMA-assisted therapy might affect withdrawal symptoms, such as delirium tremens, where people who have often severe alcohol addiction and start withdrawals will hallucinate and begin to have tremors, and they have really, really distressing hallucinations like their skin crawling and so on. And while the MAP study had a large sample, they did not include severe people with severe substance use addictions, or severe substance addictions. So this would be a really interesting next step. Other interesting next steps could be direct comparisons to other gold standard pharmaceuticals, so like acamprosate, disulfiram, naltrexone. And while other psychedelics like LSD and psilocybin have been explored for things like opioid addiction, or are being explored for things like opioid addiction, smoking cessation, MDMA and a lot of other phenethylamines are relatively explored in this domain. So that would also be quite interesting to look at. One side quest, kind of, but one really interesting tangent here is that difficult experiences do happen on MDMA, and not everyone responds to MDMA, despite some of the promising results. So there's some questions as to whether co-administration might help to solve problems like that. There's some questions as to whether, conversely, MDMA might help to soften the experience of drugs like LSD or psilocybin in therapy. Now, one study in Switzerland by Owen and Gasser used a mixed cohort in terms of what they had mental illness-wise, where at separate sessions you could choose to take MDMA or LSD within, I think, 2 sessions within a set time frame overall. This one had generally positive effects, but because of the diversity of the sample, it was hard to really tell in terms of differential effects. But one study did look in healthy populations where people would take either MDMA on its own or LSD on its own versus co-administration, regarding both LSD and MDMA on its own. And they found that co-administration of MDMA did not improve the acute effects of the safety profile of LSD. And I think it was about 100 UG or 100 milligrams for MDMA, 100 UG for LSD. This should also be noted that that study only was conducted on healthy participants with no illness psychiatrically. And this sort of dynamic is just be tested in terms of a single diagnosis with separate sessions for differential administration of different substances. One study that's really interesting right now is pairing a psychedelic therapy with existing abstinence maintenance-oriented pharmacotherapy. So tapering drugs for opioid addiction, like buprenorphine, are used also for withdrawal symptoms for alcohol use disorder. And at Hopkins, there's currently a pilot study looking at co-administration of buprenorphine and psilocybin in patients with OUD. And given that alcohol use disorder or alcohol and opioids do share some some receptor interactions in the brain, and opioid antagonists are linked with reductions in alcohol consumption in clinical and animal research, there's some rationale to say that 1 to 3 sessions of MDMA-assisted therapy might adhere in adherence or transitions to treatments for withdrawals, such as buprenorphine. So in conclusion, we went over what MDMA is, its structure. We went over some psychedelic assisted therapies for addiction and got deeper into MDMA assisted therapy for alcohol use disorder after prefacing its results for post-traumatic stress disorder. We went over some of the next steps and further research. Some of the directions are quite cool. And yeah, now thank you so much for watching. I want to thank PsychedelX, the conference, and the organizers for putting up this opportunity. Being able to even speak about this is so fantastic. I want to thank my team, my talk team, Mary, our talk coach, and my fellow cohort members, Luke and Stephen. And I want to thank you for watching. And have a wonderful day or night, whatever time it is near you.